As a continuation of what you have started for the last 4 to 5 lectures, we have been talking about UTI and sexually transmitted disease. We'll continue the same topic. Dr. Zubair will talk about Neisseria, Chlamydia, Syphilis, and herpes. And Dr. Zubair, kindly proceed.
Assalamu alaikum everyone. My name is Dr. Ahmad Zubair. I'm resident urology at SIUT. I'm going to present my lecture of ongoing series, Sexually Transmitted Disease. My moderator is Dr. Faraj and my facilitator is Dr. Najibullah. So moving forward, the objectives of today's presentations are Neisseria, how to discuss evaluation, treatment, management plans for Neisseria gonorrhea, Chlamydia, Syphilis, Lymphogranuloma, venereum, and genital herpes. So what are sexually transmitted disease? These are a group of communicable diseases caused by infection with certain bacteria, viruses, or other microorganisms that can be passed from one person to another predominantly by sexual contact, blood, vaginal fluids during oral, anal, or genital sex with an infected partner. So, first of all, the basic first thing first, how to prevent, what are the clinical prevention measures? So these include risk assessment, education and counseling of people at risk, symptom identification, effective diagnosis and follow-ups, evaluation of sex partners, and screening of people at risk, which include uh, pregnant females, young, active, sexually active male and female population, and homosexuals. Gonorrhea is a purulent infection of the mucous membrane surfaces caused by Neisseria gonorrhea, spread by sexual contact or through transmission during childbirth. Neisseria gonorrhea, also known as gonococcus or gonococci, is a species of gram-negative diplococci bacteria. Here we can appreciate the diplococci. They are in two cells are joined together, and mostly during the test, they are found in the polymorphonuclear cells. Risk factors for Neisseria gonorrhea are sexually exposure to an infected partner without barrier protection, polygamy means more than one active sexual partners, male homosexuality, low socioeconomic status, history of concurrent or past STDs, early age of onset of sexual activity, and pelvic inflammatory disease. Signs and symptoms include in the female, there is vaginal discharge, dysuria, intermenstrual bleeding, dyspareunia, painful intercourse, and mild lower abdomen pain. And in males, patient presented with complaint of urethritis, urethral discharge, pain in scrotum, acute epididymitis, and low urinary tract symptoms like obstructive flow, decreased urine flow, and double streams as well, which falls in the category of urethral strictures, and rectal infection in case of pseudomy. The patient may present with pain, pruritus, discharge, or tenesmus. So, if left untreated, disseminated gonococcal infections, patient can be present with disseminated gonococcal infection, in which there is joint or tendon pain in the most common presenting complaint. And the early tenosynovitis most commonly affects the flexor tendon sheets of the wrist and the Achilles tendon, called lover's heel, and patient may present with the skin rashes as well. In the picture, you can well appreciate the joint, skin rashes and joint tenderness. And in rare case scenario, the DGI may get complicated into gonococcal meningitis, pericarditis, and endocarditis. In physical examination, you can find mucopurulent or purulent vaginal, urethral, or cervical discharge, vaginal bleeding, cervical friability. When you manipulate the during examination, the mucosa of the cervix may bleed, and there is tenderness over the lower abdomen or both adnexa and upper right abdomen pain in cases of perihepatitis. Diagnosis can be done via certain tests like gram stents, cultures and swabs, and a NET test, nucleic acid amplification test. Basically, NAT is a technique which is used to detect the particular nucleic acid sequence and thus usually to detect and identify a particular species or subspecies of organisms. In patients who may have DGI, all possible mucosal sites should be cultured as a blood and a synovial fluid in case of septic arthritis.
Gram stain is considered positive once there is 2 WC engulfed cells, bacterial cells, at least one, two, more than two, in the high power field microscope. So it considered positive once there is 2 to 3 cells, at least WC that they have engulfed 2 to 3 gonorrheal cells, bacteria.
Thank you. Moving forward, NET test, there are certain things we can perform. Amplification can be done by PCR and extended displacement assays and transcription mediated assays.
The purpose of NAT test is that to identify the specific nucleic genetic material of particular organism that can be done by polymerase chain reaction test or other types of nucleic test.
So treatment. What should be done? What must be done is early identification and after diagnosis. We have following treatment options, and we can give ceftriaxone 50 milligram IM as a single dose plus azithromycin 1 gram per oral as a single dose, or we can give him cefixime 400 milligram per oral as a single dose plus azithromycin 1 gram per oral as a single dose. Or in single drug therapy, we can give ceftriaxone 250 milligram alone as a single dose, and cefixime 400 milligram per oral as a single dose as well. But there are high chances of treatment failure as well. So in cases of cephalosporins is contraindication, so we can give patient azithromycin 2 gram oral single dose plus gemifloxacin 350 milligrams orally, or IM gemifloxacin 320 milligram, or IM gentamicin 240 milligrams as well. If treatment failures occurs, the WHO says to treat with the following dual therapies, and ceftriaxone 500 milligrams IM as a single dose plus azithromycin 2 gram per oral as a single dose. So basically, we have to double the strength of the antibiotics to cover the to prevent the treatment failure. And cefixime 400 milligram orally as a single dose plus azithromycin 2 grams per oral in a single dose. Or we can alternately give gentamicin 240 milligram IM as a single dose along with azithromycin, or spectinomycin 2 grams IM as a single dose plus azithromycin 2 gram per oral as a single dose. Moving forward to chlamydia, what is chlamydia? It is chlamydia are
before moving forward, the treatment also includes contact tracing and then avoiding.
Yes.
It's very important.
Yes.
Because treatment failure is very common, and for treatment failure, we do different combinations. Not just to treat the strength. It is the same principle if you had in tuberculosis.
Right.
Different combination of drugs to avoid the resistance, because you know that our population is resistant. Worldwide population is resistant to that. So that is why they use combination to avoid that resistance.
I agree, and usually we focus here on the patient. A partner should be treated also, and any sexual contact with any partner in the last 60 days, they should be evaluated and tested and also treated. That's how to prevent further transmission of sexually transmitted disease.
Thank you, sir, Dr. Shua, for treating, adding some valuable points. One thing more, patient must be abstained for sex after treatment for 7 days at least. And the contact partners, as sir said, should be the active sexual partners the patient has indulged with must be within 60 days, so must be treated as well. Moving forward to chlamydia. Chlamydia are small gram-negative obligate intracellular microorganisms that preferentially infect squamous epithelial cells. They include the generic chlamydia, of which type of species is Chlamydia trachomatis and chlamydophilia. Chlamydal infections can cause disease in many organ systems, including genital tracts. Chlamydia trachomatis can be differentiated into 18 serovas. Serova A, B, BA, and C can cause a serious eye disease endemic in Africa and Asia that is characterized by chronic conjunctivitis and can lead to blindness. Serova D and K here can cause genital tract infections, and Serova L1, L2, L3 can cause a genital ulcer disease in tropical countries known as Lymphogranuloma venereum. The etiology of chlamydia, the multiple sexual partners or new sexual partner, younger age group from 15 to 24, mostly 19 age or early 18 age, poor socioeconomic conditions, exchange of sex for drug or money, single marital status, intercourse without a barrier contraceptive, history of a previous STD or concurrent co-infection with another STD. So here, one thing is very important. Whenever a patient got a single type of STD, like is a patient has Neisseria gonorrhea, so one should evaluate or test for the other STDs as well, including the herpes, chlamydia, and syphilis. What are the signs and symptoms of the patient present having chlamydia? In females, patient complaining of dysuria and yellow mucopurulent discharge from the urethra and vagina. Abnormal hair, one thing is important. In the Neisseria gonorrhea, there is whitish colored thick fluid per urethra, and in chlamydia, there is yellowish colored mucopurulent discharge. And abnormal vaginal bleeding and dyspareunia, proctitis, or rectal discharge, or both in case of receptive anal intercourse, and patient can be present with fever and abdominal pain. In males, urethral discharge, history of sexual activity without condoms or condom failures, proctitis, rectal discharge, or both in case of receptive anal intercourse, unilateral pain and swelling of the scrotum, fever, and no symptoms in 50% of the patient. So, if left untreated or undiagnosed, the chlamydia can lead to epididymitis, Reiter syndrome, scarring of the fallopian tubes, pelvic inflammatory disease, pelvic pain, and infertility. What is Reiter syndrome? If anybody can ask me, so Reiter syndrome is also known as reactive arthritis. It is a classical triad of conjunctivitis, urethritis, and arthritis occurring after an infection, particularly those in urogenital or gastrointestinal tract. Diagnosis is almost the same. We perform urethral swab test and or first catch urine for NET test, as we previously discussed how to get the NET test done. And NETs using first catch urine are the most sensitive tests for detecting trachomatis infections in men, and as such are the recommended tests.
For gonorrhea, it is recommended that the culture swab should be set for NAT. But in case of chlamydia, the fresh catch urine sample is preferred as a method of sampling for NAT test in case of chlamydia. And once patient is diagnosed with anyone, either chlamydia or gonorrhea, he should be tested for all other sexually transmitted disease like HIV and syphilis and others.
Treatment for chlamydia includes azithromycin 1 gram orally as a single dose, or doxycycline 100 milligram orally twice a day for 7 days, or one of these alternatives. Levoflox, we can give levofloxacin 500 milligram orally once a day for 7 days, or erythromycin 500 milligram orally 4 times a day for 7 days, or ofloxacin 300 milligram orally twice a day for 7 days. Again, all partners within 60 days from onset of symptoms should be treated and evaluated and treated. A test for cure is generally recommended after 3 months of the treatment. Before this period, it is invalid cause of residual pathogens derived nucleic acids. So NETs can be showing false positive after treatment as well. Moving forward, syphilis. Syphilis is an infectious venereal disease caused by the coiled spirochete treponema pallidum. Transmission. The transmission of syphilis is via sexual contact with infectious lesions, mother to fetus in utero, via blood transfusions through breaks in the skin that come into contact with infectious lesions. All patients with syphilis should be tested for HIV infection as well, because there is 77 times for increased risk of HIV in a patient with syphilis as compared to general population. If left untreated, it progresses through 4 stages: primary, secondary, latent, and tertiary. In the primary, the incubation period is 10 to 90 days, characterized by the development of an ulcer with a regional lymphadenopathy. The ulcer is usually painless, single, indurated with a clean base discharging clear serum. And here we can appreciate this. Secondary syphilis. Secondary syphilis arises from the development of bacteremia. It occurs in up 3 to 5 months after the initial infection. Maculopapular rash involving the palms and soles. Here we can appreciate the maculopapular rash in the soles of the patient, and mucous membranes lesion involving the vagina and anus. And patient may have additional symptoms of fever, lymphadenopathy, alopecia, and weight loss. The third phase is a latent phase, in which it defined as a seroactivity with no clinical evidence of disease. 2 types: early versus late latent syphilis. Early latent syphilis include patient with positive serology test for syphilis preceded by a negative serology within 1 year or recent infections. Tertiary syphilis. About 35% of individuals with late latent syphilis will develop the late manifestation of syphilis, including neurosyphilis, cardiovascular syphilis, and gametous syphilis. Incubation period is 5 to 12 years. In this, there are 2 syndromes occur: spinal cord syndrome, just Tape's dorsalis, and brain syndrome, which is we generally call the paralysis of insane. A brief description, and we can appreciate in the primary there is chancre lesion. This is hallmark of primary syphilis we already discussed, clear base with discharging serous. And then secondary can lead to oral ulcers and neurosyphilis, and I can have a perihepatitis as well. In the latent, there are 2: early latent and late latent, as we discussed. And late tertiary patient with neurosyphilis symptoms and gumas. What are gumas? They are an ulcerating granulomas on skin, bones, and internal organs. Complications of syphilis. It can lead to cardiovascular, if untreated, can lead to cardiovascular diseases, CNS disease, and dementia and stroke, membranous glomerulonephritis, paroxysmal cold hemoglobinemia, irreversible end organ damage and disfigurement by gumas. And as we previously discussed, the gumas are the ulcerating granuloma of the skin, bones, and internal organs. And in paroxysmal cold hemoglobinemia, it is a form of autoimmune hemolytic disease, anemias. In this, red cells are targeted by autoantibodies known as Donat-Landsteer antibodies. And it is triggered with the infectious disease, syphilis. Diagnosis can be done by a following test: dark field examination, venereal disease research laboratory test, rapid plasma reagent, fluorescein treponemal antibody absorption test, treponema pallidum particular agglutination test, and enzyme immunoassays. Treatment with the stages of syphilis. In primary, secondary, and early latent syphilis, with no neurological involvement, we can give a single dose of benzathine penicillin, 2.4 million units, or in case of penicillin allergy, we can give him doxycycline 100 milligram per oral BID for 14 days, or tetracycline 500 milligram per oral QID for 14 days. And late latent or latent syphilis of unknown duration with no neurological involvements, we can offer patient benzathine penicillin 2.4 million units IM once a week for 3 weeks. Or if in case of penicillin allergy, we can offer doxycycline 100 milligram per oral BID for 28 days and tetracycline 500 milligram per oral QID for 28 days. Treatment with for tertiary late syphilis with no neurological involvement, benzathine penicillin 2.4 million units intramuscular once per week for 3 weeks. In case of penicillin allergy, infectious disease department should be taken on board. In neurosyphilis alternate regimes, we can give him aqueous crystalline penicillin or procaine penicillin 2.4 million units or plus probenecic acid, probenec acid 500 milligram per oral QID, both for 10 to 14 days. Patient should inform about the gerish hexamy reaction for the first 24 hours of penicillin. It is because of the bacterial load rather than the allergic reaction to the penicillin. So patient must be counseled about it beforehand. Moving forward, lymphogranuloma venereum. It is an ulcerative disease of genital tract. Gram-negative bacteria, Chlamydia trachomatis, serovas L1, L2, and 3 are the causative agents. It has 18 serovas, and let me discuss. Lymphogranuloma venereum symptoms are classically divided into 3 stages. Local infection, primary stage, regional dissemination fall into secondary stage, and in tertiary stage there is progressive tissue damages. About 2 to 6 weeks after the primary lesion appear, regional tissue invasion occur with constitutional symptoms with penile, urethral, or bulbular inoculation. Penile, and if and there is inguinal syndrome, they're characterized by unilateral painful inguinal or femoral lymphadenopathy known as BBOIs. If untreated, can lead to genital elephantiasis. Inguinal nodes are common in male patients, as the lymph drainage of cervix and vagina are to the retroperitoneal lymph nodes. Diagnosis is based on clinical suspicions, epidemiological information, and the exclusion of other etiologies. Genital lesions, rectal specimens, and lymph node specimen can be tested for Chlamydia trachomatis by cultures, direct immunofluorescence, or NETs. Treatment of lymphogranuloma is the recommendation is doxycycline 100 milligram orally twice a day for 21 days. And alternate regime is erythromycin based 500 milligram orally 4 times a day for 21 days. Herpes. Herpes simplex virus is 2 types, type 1 and type 2 are double-stranded DNA viruses. Most cases of genital herpes are caused by herpes simplex type 2. During pathophysiology of the herpes simplex, during primary infection, HSV infects epithelial cells and then nerve ending, followed by retrograde axonal transport to establish persistent infection in the sacral ganglia, entering into a latent state. And during reactivation, the virus travel down the axon to the skin and mucosal surfaces, and where the viral shedding may lead to genital ulcers. And periodic recurrence of genital, anal, or perianal ulcers are the hallmark of genital HSV infection. Median recurrence of 5 recurrence in the first year after primary infection with genital HSV2, and the recurrence and median recurrence of 1 recurrence after infection with genital HSV type 1. Clinical presentation. Patient can present with typical painful papular lesions progressing to vesicles and ulcer formation with local adenitis, and it arises after 4 to 7 days after the exposure. And many herpetic lesions do not have the classical appearance and can look like a fissures and fluence, and they can manifest as a vulvar erythema in women. Diagnosis. Diagnosis is done by HSP PCR and type specific HSP serologic assays and that are herpes simplex specific glycoprotein GS2 and glycoprotein GS1 for herpes simplex virus type 1. Recommended treatment regimens for first clinical episodes of genital herpes. We can give patient acyclovir 400 milligram orally 3 times a day for 7 to 10 days, or acyclovir 200 milligram orally 5 times a day for 7 to 10 days, or valacyclovir 1 gram orally twice a day for 7 to 10 days, or famciclovir 250 milligrams orally 3 times a day for 7 to 10 days. This is treatment regimen for first clinical episodes of genital herpes. And the recommendation for suppressive treatment for recurrent genital herpes is acyclovir 400 milligram orally twice a day, or valacyclovir 500 milligram orally once a day, or valacyclovir 1 gram orally once a day, or we can offer patient famciclovir 250 milligram orally twice a day for 7 to 10 days. And the recommended episodic treatment regimens for recurrent genital herpes is acyclovir 400 milligram orally 3 times a day for 5 days, or we can offer him acyclovir 400 milligram orally twice a day for 5 days, or 800 milligram acyclovir 3 times a day for 2 days, or valacyclovir 500 milligram orally twice a day for 3 days. Valacyclovir 1 gram orally once a day for 5 days can be given, or we can offer patient famciclovir 125 milligram orally twice a day for 5 days, or famciclovir 1 gram orally twice daily for 1, or famciclovir 500 milligram orally once, followed by 250 milligram twice daily for 2 days.
This is a little scenario of one of the cases that you may face in OBD. 23 years old male presented to OBD with a complaint of dysuria and urethral discharge for the last 7 days. What is the most important questions in history you should ask this patient initially? Dr. Shrijan, initial questions for history on such a patient, the young patient presented with urethral discharge and dysuria.
Hello. I would like to ask the patient about other associated symptoms which the patient might be having, the duration of the symptoms since when the patient is having, and most important questions in case of urethral discharge is going to be any contact history beside his partner, unprotected intercourse commonly, and also a recent transfusion or maybe any recent
yes, an instrumentation or any sort of thing. But in young patient, most of the causes are due to sexually transmitted diseases. But in old age patient with a history of urinary tract symptoms, most of the time they are not related to the sexually transmitted disease. So young patient, you should focus most of your history on the line of sexual contact or and what are the most common organism causes of sexually transmitted disease in such age causing urethral discharge? Dr. Kausar?
So it could be Neisseria gonorrhea or Chlamydia trachomatis and Treponema pallidum.
Okay, what the color of discharge in case of chlamydia?
It could be mucopurulent or mucus.
Yes, it is yellowish mucopurulent in case of chlamydia and it whitish clear in case of gonorrhea. And If a result came to be positive, the patient should be tested for all other types of sexually transmitted disease, including syphilis, HIV, and ETIC. And sexual partner should also be evaluated for the possibility of infection, and he should be treated also. Diagnosis के लिए most of the time you either culture swab, gram stain swab, or NAT test. Proceed.
So that's it.
Prevention. Cure is better than prevention. Prevention is better than cure. Sorry. What are the prevention measures that can be taken to prevent sexually transmitted disease? Anybody? We have talked about it on the initial slides, but I need someone to summarize it. Dr. Noman.
The prevention of sexually transmitted disease is started from the school education, where they in abroad they tell you about the safe intercourse and use of the barriers. Number one. Number two, the proper genital hygiene and avoid polygamy.
Yes. And identifying those with high risk group like young age sexually active people or homosexual patient, they should be screened at least. And any addition, Zubair, regarding prevention?
Prevention, we previously discussed in this presentation. We have to do the risk identification. As sir said, the young population, male homosexuals, and pregnant females, and are the high risk groups. The preventive measures are contraceptive, barrier contraceptive, and use of condoms, and avoid sexual contact with the sex workers who are more prone to get having STDs or having multiple sexual partners without barrier protection. So these are the basics, and that's it.
Sir, a question. Such patients should be treated in a urology unit, or should be we should take opinion from infectious disease team. So maybe they have their approach for controlling such disease.
First of all, these patients are seen by a urologist for the very first time. So the initial recognition of the disease is very important. What has lost in the past few years, or maybe many years, 10, 20, 30 years, is urologists, they tend to forget all these signs and symptoms which are actually there in their textbooks as well as in their atlases. So we have to revisit the same practice, because if we don't diagnose them just by seeing all these lesions, for instance, a gamma or an ulcer over the glans penis, we will not be able to direct them to a proper person, for instance, the infectious control person. So infectious control team always comes as a next step, not as a first step. So it's the second team, not the first team. The first team is actually the urologist or maybe the primary physician, because these are the conditions which are there in the community, and they spread within a cluster, they spread within a group. So for instance, if these lesions are there in migrant workers, in those people who are away from their home, maybe your law enforcement agencies, because they are not living in proper conditions. So they live in closed rooms where there are many people sharing the same bed. Every 6 hours there is another person sleeping on the same bed. So if a person has got a disease, then that soiled cloth which is over, or a bed sheet which is over the bed, is actually transmitting the disease. So you see, there are many factors which are involved with transmission of the disease and the actual spread, and that can only be predicted and picked up by somebody who is very much inclined to do it, and that has to be a primary physician plus a urologist. Because this is our job. This is our job. We cannot just shrug ourselves that this is not our job. And all these lesions, for instance, lymphogranuloma, venereum, and conditions like syphilis. Now, syphilis once was thought that it was gone. It was gone from the face of the earth, but it is something which is still present. Which is still present, as I have said, in cluster groups. It is still present after the COVID era, and during the COVID era, these conditions they emerged all over the world in different parts of the world because of many different reasons. But the one reason that is very common was immunosuppressed patients. So we have to again go back to our own books and try to read through it and try to figure out our own patients, whether they have it or not. Because once they have it, either it will be confined to the person, it will be treated by nature, or maybe it spreads to a very devastating condition. For instance, in the case of syphilis, it can go on to something which is like neurosyphilis, and we have got a lot of cases recently reported with neurosyphilis. They have lost their eyeballs, for instance. So these chapters, again, I emphasize that you must read it through. All of us, not only juniors but also seniors. And these are the questions which should be asked in an exam, because unless and until you ask something in the exam, nobody will go and just do some hard work in remembering all these things.
Yes. Thank you, sir. Thank you. Yes, Kaushal?
Sir, can this gonococcal or non-gonococcal urethritis may progress to up to obstructive loose sort of thing, maybe stricture?
Yes, definitely.
And what should be our approach?
Initially, identifying the cause and treating the cause in the initial stage, that is very important. If a stricture has been formed already, they should be treated as a stricture case. And if most of the time, after a few months, you will not find that bacteria that caused this stricture, but you can evaluate that patient and treat it, then treat according to the stricture protocol.
Thing is, whenever there is a stricture, there has to be an etiology. So always ask this question to yourself and to the patient, how this thing comes up. For instance, there is, I don't think so, there is any condition where there is no etiology and a person, whether a male or maybe a female, comes up with a stricture disease. So a stricture had got to have some link with an etiological factor, whether it is trauma, whether it is recurrent infection, whether it is infection because of atypical bacteria. These things must be asked and must be looked into. It's a kind of a police work, but you have to do it, because if you don't do it and try to just overcome the fistula, the stricture by any of the reconstructive techniques, then either the technique will fail, or maybe you will not be able to contain the actual process of stricture formation. So it will recur. So in order to have a proper understanding and proper result out of a very good procedure that you have done, I think a few minutes time and a few days investigation is always necessary.
Yes.
I am writing points.
Yes, Roman?
Sir has rightly said that there must be there is an etiology for urethral stricture. In gonococcal or STD strictures, most commonly affected areas anterior urethra. and most of the time there are multiple strictures are the pan-urethral strictures in the gonococcal infectious urethral strictures. So always take history and see the age of the patient. If it lies in the young age, then must be asked about the contact history or any urethral discharge prior to development of the urethral strictures.
Thank you, Dr. Mazhar. Dr. Noman, you have.
Sir, I have a query from you that if a patient is having a urethral discharge and a swab test, you confirm that is a gonorrhea, Neisseria gonorrhea, and you have treated a patient, how is it possible that that patient can never have a stricture from this gonorrhea infection, or he would ultimately would lead to the stricture formation in later on in his life after the treatment?
Most likely, initial identifying and treating the patient in initial stages won't lead to stricture most of the time. But stricture may happen if we can't obscure that. But initial treatment, most of the time, 80 to 90%, in my opinion, they will not get a stricture in future.
This active disease usually is extended in many weeks. That is duration of the disease.
Yes.
There is more chance to have is pan-urethral stricture, mostly pan-urethral stricture or simple stricture also.
Yes, sir. That's what I was saying, that initial early identifying and treating the disease, it will prevent further formation of a stricture in future. But if a stricture can't be ruled out, a stricture may happen in future, but with a less frequency or less chance.
Thank you.
Thank you.